Hi, I'm Sushan and welcome to this online tutorial by Quest. In this tutorial, let's focus on diagnosis and management of chronic hepatitis B. Well, in diagnosis of hepatitis B, the first marker is hepatitis B surface antigen. If this marker is present for more than 6 months in serum, that's a marker of chronic hepatitis B. The other marker is anti-HBC. An IgG of anti-HBC is seen after 6 months of infection, and if it is present along with hepatitis B surface antigen, that's again a marker of chronic hepatitis. But the most important marker for us is hepatitis B E antigen. This is a marker of replication of the virus and also infectivity of this patient. If this HBe antigen is present for beyond 3 months, that is a marker of progression towards chronic hepatitis B. Two more important blood tests are presence of elevated ALT, which is a marker of ongoing hepatitis, and HBV DNA levels. Elevated HBV DNA levels tell me that the virus is still replicating and there is ongoing risk of damage. Now, why do we want to treat? What's our goal of therapy? Well, ideally, I would want that hepatitis B surface antigen should disappear. That means the virus is cleared. But we know that's going to happen in a very small number. 0.1 to 2% of cases are actually going to achieve that. So a more practical goal for therapy is going to be decreasing the replication of the virus, getting the DNA to a non-detectable level, and stopping the inflammation. That means getting the ALT to normalize. So whom should I treat? What are the indications for therapy in chronic hepatitis B? Remember, I do not treat acute hepatitis B with antivirals because most of them are going to be self-resolving. But if my patient has chronic hepatitis and ALT is more than 2 times the upper limit of normal, I would be now looking for HBe antigen. If HBe antigen is positive, that is the immune clearance phase of the patient. Here, if the DNA levels are more than 20,000 international unit per ml, that's an indication for therapy. But in a patient who has elevated ALT, if HBe antigen is negative, it could be the immune escape phase. Here, I would again look for DNA levels. If the DNA level is low or non-detectable, patient would not require therapy. But if HBe antigen is negative, but DNA is more than 2000 international unit per ml, then that's again an indication for therapy. Irrespective of HBe status, if the patient has liver cirrhosis and the DNA is detectable, that's again an indication to start antiviral therapy. Similarly, irrespective of HBe status, if the patient has a family history of hepatocellular carcinoma or a family history of cirrhosis, that puts our patient at a high risk of developing these complications. So irrespective of their HBe status, such patient should be offered therapy. Now, do I need to biopsy any patient? Well, yes. Think of a patient who is HBe antigen positive. DNA levels are more than 20,000 international unit per ml, but ALT level is less than 2 times the upper limit of normal. Now, such a patient could be either in the immune tolerance phase and therefore there isn't inflammation, or he could be in the immune clearance phase but has a low level of inflammation. How would I know that? Well, the best way to know the inflammation is to do a biopsy. So in such a case, if the patient's age is more than 40, if the patient has a family history of hepatocellular carcinoma, or the ALT is at least marginally elevated 1 to 2 times of the upper limit of normal, such patient should undergo a biopsy, and if there is presence of inflammation, such a case should be considered for antiviral therapy. Now let us have a look at the antiviral drugs that we have. The oldest drug that we have are the interferons. We have interferon alpha and the pegylated interferon alpha, which is a longer acting drug. Advantages of interferon is that it has a fixed duration of therapy. 48 weeks of therapy is what is offered. Also, virus does not offer any resistance to interferon, and the rate of conversion to HBs antigen negativity is higher with interferons. But the problem with interferon are its adverse effects. Also, it is a costly therapy and injectable therapy. So interferons are not the preferred drugs now. The preferred drugs are the nucleoside analogs and the nucleotide analogs. The commonest example of nucleoside analog that is used is entecavir, and the nucleotide analog that is used commonly is tenofovir. Either one of these, usually tenofovir, is the monotherapy that is now the preferred therapy for chronic hepatitis B. Now, this therapy is to be given lifelong, unlike interferon, which had a fixed duration of therapy. We can consider stopping therapy if some of these patients develop HBs antigen negativity and preferably anti-HBs antibody positivity. One can also consider stopping therapy 1 year after HBe antigen has become negative. 40 to 80% of such patients can have sustained response and we can take a risk of stopping therapy. But remember, if the patient has already developed cirrhosis, then we prefer to give lifelong therapy. The one thing to remember about tenofovir especially is that we need to monitor renal functions because the drug is nephrotoxic. To summarize, in case of chronic hepatitis B, our goal of therapy is to decrease replication of the virus, get the DNA to a non-detectable level and stop the inflammation, that means get the ALT back to normal. Our therapy depends on HBe status. Our indications would vary whether the patient is HBe antigen positive or HBe antigen negative. But if the patient has cirrhosis, then we definitely consider therapy based on the HBV DNA levels. The preferred therapy is monotherapy, usually with tenofovir or with entecavir. And this monotherapy in most cases would be a lifelong therapy. If there are any questions regarding hepatitis B, feel free to discuss with me on the Quest tab or during our lectures. Thank you and Jai Hind.